All right, threats to nutrition, child and adolescent. The first slide I'm going to talk about is just going to be, or the first diagram, you can write as much or as little as you guys want. It's going to be mostly just review stuff, so I wouldn't get too upset if I'm going a little fast with this one. But we're just going to talk about basically the principles of nutrition, the GI function, health history assessment, diagnostics. And because I go over this kind of fast because this is a broad overview of the GI, but when we get to each system, then we're going to talk about the diagnostics that are specific to that system or the clinical manifestations that are specific for that system. So when we're talking about history, we're going to ask the family, ask the parents, ask the child any problems that they're having related to their GI function. So are they having any abdominal pain? Are they constipated? Do they have diarrhea? Have they had a change in their appetite? Are they having any heartburn? Can they all of a sudden not eat a certain food because it doesn't agree with them? Are they have any gassing, any bleeding, rectally? Anything that's kind of out of the ordinary. So we're going to talk with the families and the kid, what's going on with your GI system. And do people like to talk about poo? No. Okay, so it's always sometimes a sensitive subject. So you have to be direct a lot of times and make it like it's no big deal because people don't like to talk about their bowel functions. I don't know why. Me and my kids talk about it all the time. You're going to get any history of GI disease. Do they already have a history of Crohn's or celiac or one of those? Are they on any medications, especially over-the-counter medications? So they may say, we have no GI issues at all, but I take 4 Tums every 4 hours every day. And you'll be like, well, do you have heartburn? Well, yeah, but, that's not really a problem. I just take my Tums and it's better. So a lot of times they may report no problems. Ask them about their medications. What meds are you taking, especially those over-the-counter meds, because they might just be kind of self-treating and not really understand that there's an issue that we could be fixing. Any past surgery? Do they have any allergies? What's their current nutrition like? How are they eating? Are there any foods that they avoid? Anything that gives them trouble? What is their elimination like? Some people poop like 4 times a day. Some people poop every 3 days. Typically we don't like to go more than a couple of days without a bowel movement, but we want to know what's normal for you. How often are you going? Is this normal for you? Do you have to strain to push down? Is it hard? Is it soft? Does it float at the top? What color is it? And these are all questions that you're all like, oh, great. But it helps us determine like where their GI status is. So again, be specific when asking those. Sleep and rest is important. Exercise, because exercise, that's why do we get patients up, besides pneumonia, that's the number one reason we get patients up after surgery. The other big reason we get patients up and active as soon as we can, and we don't want them bedridden, is because anytime they're just laying in bed, it slows down their GI system. So the more that even exercises, help induce going to the bathroom. Stress can affect the gut. Foreign travel. So if they report something like diarrhea, where have you been? Have you been somewhere that you could pick something up? Have there been any recent weight changes? Have they gained weight unexpectedly? Have they lost weight? And is there any alcohol or tobacco use? On physical exam, we're going to look at the mouth. So that goes from the lips and the tongue, the buccal mucosa. We're going to look back at the pharynx, the uvula, all of that area. We're looking for any kind of nodules, tenderness, ulcerations, anything that might say there's something funky going on. We're going to look at the abdomen. What's the first thing we do when we do a physical exam? Abdomen. Okay, and then? Auscultate, right? Because if we press the belly, For, if we're going to palpate or percuss, we can actually create vowel sounds that aren't there. So the first thing we're going to do is inspect it and then listen to it to get the best exam. And then we're looking again at the contour of it. Is it distended? Are there vowel sounds? Is there any masses that we can feel? And then we do need, if they're coming in with a GI complaint, that you do need to examine their rectum, which again, nobody loves to bend over and show the world, but it's really important. Keep it modest, protect them. If you guys are feeling uncomfortable, they're feeling uncomfortable about it. But if they're reporting bleeding, we need to look if there's any fissures or hemorrhoids. Is there any tearing? What's going on? We're going to do all sorts of diagnostics, and we'll talk about these more when it comes to the specific diseases. But a lower GI, those are enemas. You can do barium enemas, air enemas. We're going to talk about that more in test 5 too. Ultrasounds. We can do ultrasounds of the belly, but they don't always work great, especially in adults, because if there's any significant adipose tissue, then their ultrasound's not going to get through. So they have to be so for kids, ultrasound works great. And ultrasound is awesome because there's no radiation. There's no really pre or post-op that you have to prep them for. It's not invasive. So for the most part, ultrasound is really, safe and quick and easy, but it's not as reliable because if there's a lot of adipose tissue, you're not going to get a good picture. So then they use things like a CAT scan or an MRI, and that is going to be more inclusive, give you a much better picture of showing any masses, fluid in the abdomen. But again, with those, there might be some pre-op. They may need contrast. So if they need contrast, then we have to worry about things like, do they have a good renal system to take on that contrast? It exposes them to radiation. So we need to weigh the risk and benefits. Is it worth the risk of radiation to get the benefit of the test? Labs are helpful. We'll talk about those. Biopsy, if we see anything like a mass, we'll biopsy it to see what it is. So just like lower GI enema, we can do an upper GI, which is the endoscope, to look at things. A colonoscopy is up from the bottom. And then an ERCP, it stands for, retrograde something, pyelogram. They basically can go in and grab gallstones. So it's a diagnostic procedure that is also therapeutic management. So those are one of those cool things that it tells us if they have gallstones, but we can also take the gallstones out once we diagnose them. So, and then some influencing factors, any organic diseases, do they have any other problems going on? Physical, psych, especially kids. Kids tend to have a lot of somatic pain in the belly. Like if they're scared or they don't feel good or anything, they tend to say, I have belly pain. That's not related to the belly at all, but because I'm getting bullied at school or because someone's hurting my feelings or, I just don't want to deal with something, so I'll complain of abdominal pain. Attitudes and eating habits. We talked about this a little bit before. It's hard to change a child's eating habits if they're doing what their parents are doing. And most parents don't like to be told they're not, parenting well, right? As a parent, the worst thing you could probably tell me is that I screwed my kid up, which I probably did. They're going to therapy. I've come to terms. But, it's hard to look at a family and say, you're eating horrible and now you're making your kid, fat, or because of the way you talk to them, they have an eating disorder now. And that's really hard to take in as a parent. So you have to approach it very sensitively and, really explore how the family's attitudes are and how their eating habits are and how that's affecting the child. Bless you. What are the cultural and religious preferences? There's many religious preferences. They don't eat meat, can't eat on certain days. They may fast. So and the financial status of the family. But basically, the main function of this GI is to supply nutrients to the body cells. And it goes from your teeth to your anus. Oh, does anyone need me to go back? Are you guys all good? All right. So we're going to talk about malnutrition first. These poor little kids. So these are most prevalent in developing countries. Particularly, other risk factors include like low social and economic status, poverty, and there are some conditions that put them at risk, like decreased mobility or malabsorption syndrome. But we're going to talk about these three main ones that are, malnutrition. First one is the protein calorie malnutrition. And this is the most common form of malnutrition. And it's basically just because they don't eat well. They have poor eating habits. There is primary and secondary. Secondary means that there's some kind of alteration and defect. They either don't take it in, don't absorb it, don't, get rid of it the right way. There's some kind of anatomical defect or some kind of disease process that causes them to not absorb or take in nutrients the way they're supposed to. But for the most part, people just get protein calorie malnutrition because they don't eat good. They don't get enough of it in their diet. So we have these two types. This Marasmus, which is this little dude right here. My picture got cut off a little bit, but you guys have it in your slides, I think. This is a calorie and protein deficiency. It's a severe form of malnutrition. These are the pictures of these kids that they use on the commercials to make us feel bad to send money, right? For the starving kids in like Africa that they say. These are severe form of malnutrition. It's typically prior to 1 year of age. And again, it's caused because of poverty and no food supply. I went a little too. Oftentimes we'll see that they have some kind of infectious disease too, because their living conditions aren't great. So then on top of it, they get diarrhea, which doesn't help the situation. But oftentimes it's just because they don't have the food to take in. So their little bones look like they're wrapped in skin. So you can see all their bones. They actually have normal protein levels because it's kind of that balance. It's not like they're getting calories but not protein. They're not getting either. So their protein in relation to everything else is within normal limits. So even though there's a deficiency, does that make sense? They typically have normal protein levels. They get kind of wrinkly skin. They have a sunken abdomen. And that's the biggest way, one of the biggest ways you can tell the difference between Marasmus and Kwashiorkor.
Is this called the same thing in adults, or this?
Mm-hmm.
Okay, because I had a patient with this, and he looked normal.
Yeah.
Perfectly normal. So I was like,
Yep, it looks the same. He wasn't like,
no, nothing at all.
well, maybe then he had a history of it?
No.
Yeah, they're the same.
Because I was like, he looks pretty.
Yeah, no, they should look like this. Because it's, like I said, it is a severe form of malnutrition.
Yeah, because I Googled it, like, at the hospital.
Mm-hmm.
The instructor was like, oh, look it up. So I'm like, okay. And I'm like, okay, they misdiagnosed this guy, or what?
Yeah, no, they have they look just sunken in. So they have no body fat, so they have no way of really regulating their temperature. So they're oftentimes hypothermic. And they have clinical manifestations secondary to their vitamin deficiencies. So if they don't have enough vitamin D, their bones are at risk. If they don't have enough vitamin C, if they don't have the minerals and vitamins, because they're deficient in that, they'll get those secondary manifestations related to whatever they're lacking. So it just depends on their diet and what they are getting. So obviously we have to treat the cause, and the cause is that they're not eating. So this is a person, we just can't take them in and say, okay, here's a cheeseburger, go at it, because their system is not used to handling that. And if you give them, really heavy foods or introduce too fast, you can actually cause the diarrhea to get worse and things get worse. So you have to kind of reintroduce food slowly back with them.
Dr. Daniels?
Uh-huh.
What is that word after CM2?
Clinical manifestations secondary to vitamin deficiencies. And then you're going to treat any complications. And like I said, you need to supplement slowly. We can't just say their problem is no food, feed them. If you feed them too fast, you can actually make the situation worse. Anyone ever watch like Survivor and they haven't eaten for like 3 weeks and then they like win the reward and then they're all like in the bushes throwing up and with diarrhea because they just gorged and they're not used to it? It's the same thing. Because their system has kind of shut down, and to wake it back up, you have to wake it back up slowly. Do they still have Survivor on TV? Yeah. All right. So Kashi-Core is more rare because this is where they have a sufficient amount of calories, but they're just not getting protein. And a lot of times it's because moms are breastfeeding, and when they're breastfeeding, they get calories and protein from their mom, so they're doing really well. And then all of a sudden, mom gets pregnant with the second baby, and the second baby pops out, and mom puts the baby on the boob and tells, big sister or brother, no more. And then they then go and like their diet changes fast and significantly. So now they're still getting calories because maybe they get a lot of rice and bread and those type of things. So they get the calories that they need, but they're no longer getting like the protein that they need. So they appear well nourished, but they have very low protein levels. Because unlike Maramus, where everything kind of, we lost calories and protein at the same time, now we have calories that are still coming in, but we're not getting protein. So that's where you get that low protein level. They get edema. So remember, protein is like albumin, right? And albumin helps with that oncotic pressure. What's oncotic pressure? It helps pull water back in, right? So if I don't have enough protein, albumin, to keep my, that oncotic pressure high, fluid is going to start leaking out in that interstitial space. So that's why they tend to get edema, especially on the ankles and feet, things that are dependent. And then they get the big old belly. They get a round, swollen face. You have to be careful with fluid shifts, like things like mental status changes, because the fluid is shifting. They have really hypertrophic muscles, so although they appear well nourished, they're not like, they don't have normal muscle development. Skin changes. They're thin, gets like kind of like a reddish color. The skin is like brown and peeling off. And again, the treatment is the diet. They need protein in their diet. And again, we can't just throw a bunch of protein at them and say, here, eat these 7 steaks. They do have to slowly reintroduce. And although these kids look sicker, the Maramus kids look sicker, they actually have a better prognosis. Just because think of it, it's balanced. All right, everyone good at that one? Okay. All right. So, when we talk about things like obesity, anorexia, and bulimia, they are forms of malnutrition too. So, continuing on with that, we're going to talk about obesity. And obesity is greater than 90th percentile. So your BMI. So does everyone know what BMI is? Body mass index. And you figure out your body mass index by kilograms divided by your height squared in centimeters. Now, I know there's lots of arguments out there about BMI and how accurate it is. And according to the BMI, I am severely obese. So, awesome. So, there is some questions about how exactly. I mean, I know that I got a few lbs I could lose. But, I wouldn't say I was severely obese. So, but that's okay. Gives me some goals. But so people do argue that the BMI is not totally accurate, but it gives us somewhere to, something to work with. Oh, and I have right there. So an increased BMI means that the body weight, we have increased body weight secondary to excessive body fat. And the reason people argue is that, people with muscle might weigh more, and that doesn't really mean that they're, fat. They just have more muscle or whatever. But for all intents and purposes, for the majority of people, if you have a high BMI, it means that you have a lot of body fat. Too much. God bless you. And there are a lot of things that, contribute to this. And we always think of that you just eat too much, right? That your intake exceeds how much you expend. But there are definitely some family influences, not just because they might be poor role models, but there are genetics, that come into play with this. There's definitely a familiar hereditary component with obesity. There might be environmental factors. Children who don't have access to parks or playgrounds. Kids whose parents may work long hours and so they can't go outside and play or just don't have that exposure, are at increased risk because they don't, they eat what would be maybe a normal amount for a child, but because they're not out there expending it like a normal child would, they gain weight. We have an influx of video games and TV, right? And those are super fun to sit in front of. And that, you don't burn many calories going pew, 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 right? So we definitely have those kind of environmental factors. We've got social factors. There's things, McDonald's wants to supersize it and your peers pressure you. How many of you go out and you're like, no, I'm not going to have that cake. And then you shove 4 pieces in your face because your friend is eating it, right? So there's cultural factors. The family meal is decreasing, sitting down. How many of you guys sit down at the table every night with your family? There's 3 of us.
Now we get home so late,
but we see a decline, and that used to be a big thing. You would sit down with your elder parents or with your older children or whoever and have a big sit-down family meal. How many of you eat in your cars on the way to clinical? That's like, I mean, well, I know. Yeah, how many of you are eating in your car on the way home from clinical? I mean, I'm sitting up here eating right now as we talk. So there's been a shift in those, that change from sitting down. And then psychological factors. Less than 5% of obesity problems have to do with an actual disease. Like Prader-Willi syndrome, where they can't stop eating. That's less than 5%. 95% of obesity cases have some kind of mixed component. It's never just one thing, it's a combination, which is why obesity is so hard to treat, because it's never just, oh, we're not sitting down to dinner as a family, so we're going to sit down together and I'm not going to be obese anymore. No, there's other things going on. So we diagnose it by their history, by their weight, by their BMI. We can do a CAT scan or MRI if we think there's some kind of disease process causing it. So maybe they have a big abdominal tumor because they weren't obese 6 months ago, but now they just gained 20 pounds. Well, that's not normal. That's why we want to ask those things, like ask why, have you gained weight? How fast have you gained it? Because it could be something like a tumor. We might get labs, like cardiac labs, glucose. Make sure that this isn't leading to secondary complications or conditions. And we might even get a sleep study if their obesity is causing them to not rest well at night. And again, that's why we ask about rest and sleep. So the biggest treatment is prevention. If we cannot get there in the first place. That's why peds focus so much on anticipatory guidance and like going and talking with the parents about what to expect and trying to prevent it in the first place. Obviously, diet modifications. How many people in here have ever been in a diet in their entire life? Right? At least once, right? Right? Have you, like, at least once for one day, you might have said, I'm on a diet today. Maybe that was off by lunch, but I guarantee you, most of you have started at least and said, oh, I'm going to eat healthy today, right? There are drugs, that's obviously not recommended all the time. The big thing would be the diet modifications. I know some of the big stuff right now, they do vitamin B12 shots to help. But the problem is that once you take those drugs away, if you haven't made diet modifications, you're just going to gain that weight back. Bariatric surgery, we've heard of that, where they go in and basically clip or make the stomach smaller so that they don't intake as much. But there are things that people forget. Alcohol does not take up a lot of space in your belly, but it still has a lot of calories. So a lot of people are obese, not because they necessarily eat a lot, but because they take in calories through other things, like what they're drinking. People lose a lot of calories through their drinking. So a bariatric surgery, I've seen people, personally I know them, that they had the surgery done and it made no difference because they still drank away their calories. So again, it all comes back to a lifestyle change. So these other things help, but unless you're going to make a lifestyle change with your diet, you're not going to have the end result. Counseling, they may need just nutritional counseling. Maybe they think, well, I don't know, I eat healthy. I eat nuts and I have 7 handfuls of nuts every day. Like, I don't know why I'm not losing weight, when they don't realize that was like 4,000 calories there, or maybe they don't understand. Behavior therapy, getting the family involved, and of course physical activity. They say that there's studies out there that shows that to lose weight or maintain your weight, it's about 80% nutrition and about 20% physical activity. So physical activity is important, but the bigger thing is changing your diet habits. And you can't look at it as a diet, right? It's about making a lifestyle change. Yes. All right, so what are the consequences? Well, who wants to look in the mirror and not like what they see, right? So obviously, especially with adolescents, which we're going to talk about at the next test, it's their body image is very important to them. And so if they have a poor body image, it can affect other things, cause depression, cause a low self-esteem. And it can cause them to be socially isolated or even bullied. Unfortunately, kids are really mean. And like I said, bullying is starting younger and younger and younger. And kids in, elementary school, they know the term fat by the time they're like 5, 6 years old. And they use it. And they use it meanly. And sometimes they don't even mean it meanly, Like my son, I was playing around with him and sat on him. And he's like, Mommy, you're too fat for me. They don't. And so he wasn't trying to hurt my feelings. He wasn't trying to be mean. And I know that as an adult. But if he says that to another kid, are they going to take it the wrong way? Yeah, very much so. Or, just because they don't have that development there. Did I get my feelings hurt a little bit? Yes. But I took it. I was okay. And then there's all sorts of health problems that lead to adult issues. Hypertension, hyperlipidemia, diabetes, all those things. Obesity is like the number one contributing factor to all those. So on the other end of the spectrum, we have anorexia and bulimia. So anorexia is weight loss secondary to restricting calories and the types of food. So people who have anorexia may say, it's very toddler-like almost. Like I will only eat green foods because green foods are really good for you. And so I know that I'll lose weight if I just keep it to that. Or I can only eat this kind of food or that kind of food. And then they'll count their calories.
What does it say after secondary?
Restricting, weight loss secondary to restricting calories and types of food.
And then exercise.
Compulsively. One of the big things, how we diagnose this, is they're totally in denial. So there's clinical manifestations. I like how every time I have this lecture, somebody looks at somebody else in the class and smiles like, huh? So total denial. They have a distorted body image. So they tell you constantly how fat they are. I'm so fat. I'm so overweight. And they are a stick figure. Yep. See, I'll see some girls laughing about that. They have and when I say a fear of fat, it's not like I don't want to be fat. They are truly fearful. They get upset. It causes them severe anxiety. They are so upset about the fear of being fat. They tend to dress in layers. And these three things, anorexia is really hard to diagnose, right? Because it's not like a disease, it's more mental. So in psych, you will probably learn about, you guys are learning about DMX, right? Am I saying that right? The right acronym? And they have certain criteria that they need to meet in order to get diagnosed. These are the criteria that they need to meet in order to get diagnosed with anorexia. But so then these are the things we're going to see. They tend to dress in layers because they will say they're fat, and then people are like, oh my God, no, you're not fat. So they hide it. Even though they're in their denial, they'll hide it from everybody. They make frequent comments about being fat. They have food rituals, like they eat food the same way every time. They have to eat food in a certain place. It's their food and their diet completely controls them. They will not go out because they have to eat at a certain time. They, won't hang out with their friends. There's lots of things they won't do because their food and their ritual will control them. There's obviously the physical signs and symptoms. Oops. They might have teeth issues. They're not getting the calories they need, but they're also not getting the vitamins and minerals they need. So they often have those physical signs and symptoms from those deficiencies. They might chew their food. Like they may say, okay, I'm going to sit down to eat, and I have to chew every bite 50 times before I swallow. So, and they do, and that's the only way they think. Bulimia is a cycle of binging and then some kind of compensatory behavior. So it's a cycle of binging followed by a compensatory behavior. And that compensatory behavior, everyone thinks bulimia is vomiting. It could be vomiting, it could be laxatives, it could be excessive exercise, or it can be a combination of those things. Anything, it's basically, I eat, and then, oh my God, what did I just do, and how do I get rid of it? So this period where they binge can be, you know, it's a certain amount of time. It's typically a couple hours. Like they go and they consume, I've seen bulimics consume 3 large pizzas. You know, they are very good at consuming a ton of food and then immediately will take a ton of laxatives or start self-induced vomiting.
Well, I think that would make anybody want to feel like that.
Yeah, but it's cycles. They have this cycle frequently. So this isn't just one time like, oh my God, I ate all that pizza or I drank too much and I made myself throw up and then I'm done. I've not done it for a long time. They do it, you know, over several periods. And it happens at least once a week that they're doing this. They also have food rituals. They tend to disappear after meals. So they'll eat normal in front of you and then disappear afterwards because they're going to do the compensatory behavior. They don't like to eat in public, especially when they're binging, because, you know, they'll be like, oh my God, look how much you just ate. And they drink an excessive amount of water. And they also have those physical signs and symptoms. Oftentimes with them, because they're vomiting, they have breakdown behind their teeth. So that's why it's really important as you're getting a history and you're doing your physical exam to get a really good exam of the mouth, because you'll see ulcerations and breakdown behind the teeth because all that acid coming out, it breaks it down.
So why do they drink an excessive amount of water?
To feel full. To get that sense of like binging.
What's the diagnosis?
When they're not like in a binging moment. At least one time a week. That this behavior of binging and compensatory mechanism happens at least once a week. So, treatment, obviously, depending on how severe it is, these patients need a lot of help. And it's not just, well, you need to eat more, you need to stop it. There is a whole psych component related to this. They need a lot of counseling, a lot of support. Some people can handle this outpatient. A lot of people get admitted and get treatment inpatient and then receive outpatient therapy. During acute episodes, we may have to put like an NG tube or a G tube in them or TPN and force feed them because they really just don't see the damage that they're doing to their body or how severe it is or how skinny they are. And they were literally starved themselves to death. So I don't have a lot under treatment because, again, a lot of it has to do more with counseling and those type of things. Our job is that we need to make sure we're asking appropriate questions. We need to make sure we're doing good physical exams. And if we suspect this or a parent comes to us concerned, that we know that, okay, we recognize this person has a problem and we recognize that we need to get them help. All right, everyone good? And the proper dietary nutrition, you can go to choosemyplate.gov. That's the new. They used to have like the food pyramid. Now it's the plate with the cup. All right, we're going to talk about actual structural defects now. First one being cleft lip and palate. So this is a cleft lip, A and B. Cleft palate is I just tickled it. The palate up there, there's a defect in the palate itself. You can have just a cleft lip, just a cleft palate, or you can have a combination of both. So it's a facial malformation that occurs during embryonic development. And when I was reading up about it, it was kind of cool. The way your face forms, which I thought was kind of cool, it forms 3 ways. So it comes from the bottom and from the sides. And so that's where the defect happens, is that because as it's coming here and here, it just stops developing for whatever reason. And then there's a hole because it didn't, form. And that's where the cleft lip or cleft palate occurs.
Excuse me. Facial
Malformation that occurs during embryonic development. So why the baby's in the mommy's belly developing, it just doesn't form all the way. Your maxillary process, your different facial processes should come together as the little embryonic little baby's forming, and it doesn't for whatever reason. It can be because of genetics. It can be because of environmental exposure. Like smoking during the first trimester is that causes a lot of defects. Stress, both physical stress and emotional stress. There are certain drugs like alcohol or seizure medicines that are detrimental to the baby. Nutritional deficits like folate. And I thought this was an interesting, maybe you guys already know this, but the main reason they put folate in bread was to help pregnancy, to help pregnant women. So, because you need folic acid, and when you find out you're pregnant, one of the main reasons they put you on a prenatal vitamin is for the folic acid, because it helps with a lot of these defects. And we're going to talk about another one when we get to neuro, like spina bifida. And they were finding that sometimes women didn't find out right away that they were pregnant, and the most important time to get your folic acid is those first 3 months, the first trimester. And sometimes, I don't know if you are, planning or whatever, you don't know that you're pregnant until, a month or 2 down the road, and it's kind of already too late to get the folic acid in. But everybody eats bread, right? Pretty much everybody. Now there's all these diet trends now. But back then, pretty much everyone always ate bread every day, so they started adding folic acid to bread to make sure that women had enough folic acid. I thought that was pretty cool. All right, we diagnose it because you see it. You see the defect, especially if the baby's crying. So when the baby's screaming, that's a great time to examine their mouth.
Can they see this in utero?
Sometimes they can. Mm-hmm. Sometimes it's missed. Palpate. You have to palpate the hard and soft palate. If you see a cleft lip, you should be looking for a cleft palate because they're often together. But just because they don't have a cleft lip doesn't mean that they don't have a cleft palate. So newborn exams, we often palpate and make sure. And you need to describe the location and the extent of the defect, because it can be very small. It can be a little pinpoint hole or a very small hole, or the entire palate can be affected. The big thing with these kids is that it affects their nutrition, their eating, their swallowing, and they choke a lot on their feeds. So when a baby is born, what's our main goal for babies? To feed them and make them grow, right? But with these kids, their suck is a little different, right? They can't get that same seal that they need to, especially if they're bottle fed. We actually encourage breastfeeding because the breast tissue will actually form into the holes of the defect and allow the baby to still have a good seal. So most people would say, oh, they can't breastfeed because of the defect. No, it's actually kind of better for them. But they have a hard time getting a good seal with bottle feeding, and they can't get fluid at the same rate because the palate is open, meaning that now it's going into the nasal passage, it can get into the lungs, and they can choke. So we have to be very careful. And if they're not able to eat, they're not going to get the calories and nutrition they need to grow. So our focus for these kids is on their growth and development regarding nutrition, because it can lead to failure to thrive. And I've just said this. The goal is to weight gain and develop. So, like I said, we encourage breastfeeding, and we need to help the parent. It's going to feel awkward for them, and plus they're going to be scared that they're going to be hurting their baby, or that, they're going to do something wrong. The defect doesn't bother the baby. There's no pain or anything associated with it. After surgery, there will be, but initially there's nothing wrong. So we need to encourage and help the parents a lot. We need to hold them upright. Because we want to let gravity work with us, not against us. We do not use normal nipples. Like for bottles, they have a specialized nipple. So parents really need to be taught. Has a very wide base to the nipple, and it has a larger hole because they can't get that same suck. And they're going to work way too hard to get less formula than a normal baby would. So they're going to burn more calories, get less formula. That's not going to help them grow. So they use these special nipples that have bigger holes in them and that have a nice wide base so that they can get a good seal. And we do this it's called ESSR. So enlarge the nipple, stimulate suck. We want to make sure they're swallowing food appropriately. Did I write it up here? Oh yeah, enlarge nipple, suck, swallow appropriately, and give them rest when the infant signals it. Most babies, when you get anything near their mouth, they're, right? These babies have a little bit harder time because, again, they don't have that same structure there. So we oftentimes have to stroke underneath their chin, make sure that they have a good seal to help stimulate that suck. We want to see them swallowing. If we're watching them feed and we don't see swallow, that means they're probably choking on it or it's not going down. And then sometimes they just get tired because, again, they have to work a little harder. So if they're getting tired, we need to stop the feed for a few minutes, let the baby rest, and start back up again. Burp frequently. These babies often can have a nasally sound, or the kids, their voice is more nasally. Their speech can be affected. I don't think we realize sometimes how much we use our palate for our tongue to touch the top of our palate to make certain sounds. So if you tried to hold your tongue down while you're talking, I can't do it, right? So if you try to do that, you'll kind of get a feel of how much that comes into play. And if there's nothing there, yeah, that's kind of hard, isn't it? If there's no palate there for the tongue to touch, they won't be able to make those sounds. So they oftentimes have hard time with speech. There's dental issues because if the palate's not there or the lip, the teeth don't come in. They can have hearing issues, especially if fluid gets backed up in the eustachian tubes. Sinus or ear infections, again, because all that fluid is kind of backed up into the eustachian tubes. And obviously, appearance. Pregnancy is supposed to be super fun and happy, and everyone's excited to hold their brand new perfect baby. And when their baby comes out with those kind of defects, it can be very scary for the parents, and they can have a hard time bonding with them. So when we treat, it's a multidisciplinary approach. It is not because they have so many issues related to this little defect. Well, I shouldn't say little, but they have to have, pediatric surgery. Oftentimes plastic surgery is the one who does the repair. They're going to have speech involved, dental involved, ENT involved. They get to see the whole gamut. It's surgically repaired. We're going to talk about that in just a second. A cleft lip, we repair first. They get repaired at 6 to 12 weeks of age. So if we're waiting till 6 weeks, do you see why nutrition becomes such an important issue? Because for 6 weeks, the parents have got to figure out a way for the child to grow, because they need to be big enough and healthy enough to undergo the surgery. So they get their first surgery for their lip at around 3 months. And our big thing is that they can't have any infections. Skin, cold, anything. So we got to make sure they're nice and healthy, because if they're sick in any way, the lip won't heal. There is a lot of tension in this area, and when they pull it together, that you have to be very careful that they don't pop open and get infected. So they really want to make sure that they're as healthy as can be. Post-op, we really need to protect the site. So everyone who's got a kid, bless you, or has been to all children's yet or seen kids know that kids reach for everything, right? And they have, a very painful, annoying suture area up here, and they want to touch it and pick at it, right? Babies are constantly with their hands in their mouth. So now we're trying to keep them from doing that. So oftentimes we have to do pain meds for them, position them, we use arm restraints, and we can't stick anything in the mouth. So this all seems really mean, right? Because this is not what a baby would want at all. So we have to be very careful. The arm restraints we only use when they're not being supervised. But we encourage the parents to still interact, hold the baby. So take the arm restraints off and hug that baby. If they're holding the baby, stick one arm behind their back, hold them, and hold the other hand down so that they can't get to the site. But still interact and love on that baby. We only want to use it when they're not being supervised, the arm restraints. We don't want to position them, obviously, where they're going to put pressure on the face or on the sutures. We need them on their back, which babies should be on their back anyways. And nothing should go in the mouth. So we don't take temperatures in the mouth. We don't, use a tongue depressor to look in the mouth. We have to be very careful that nothing goes in there. No suction. A lot of times we use that bulb, that little blue bulb syringe. Nothing goes in there. If they're starting to feed at 3 months, they're not really starting to feed yet. But as they get to 4 months and we're introducing rice cereal, we even have to be careful about using a spoon to feed them. We got to keep the site clean. A lot of times they just use a little Q-tip, and they just use water, and they just kind of clean it with the Q-tip and then put a little ointment on it It says feeds and clean site. So our big thing post-op is to protect that site and let it heal really well. The better we let that heal, not only cosmetically they'll do really well, which is, a big reason that we do it, but it helps prevent any infections or any other worse complications. They don't do your cleft palate until they're at least 6 months old. Oftentimes it's closer to a year that they'll do it. So again, choking is still going to be a big issue for these kids because their palate is going to be open and they have access to the eustachian tubes and to the respiratory system. So feeding is not just okay, for a couple days and we're good to go. Parents have to make an adjustment for months. So 6 to 12 months old. Post-op, we're going to resume feeds as soon as possible. So as soon as they've cleared them, then we start the feeds up again. But with those feeds, it needs to be a soft diet. So nothing crunchy, hard. No toast, chips, cookies. Those little biscuits that kids love to suck on. None of that type of stuff. Again, no suction or objects. So no temperatures, no tongue depressors, no thermometers.
What does it say after ASAP?
No suction, no objects, no hard items. So you have to be careful. What do we give kids to play with at this age? Rattles, right? A big old plastic hard rattle, and they'll go bloop bloop bonk. And I've seen it. They just are playing, and they hit themselves in the face by accidentally and pop open the sutures. It's so frustrating. So it's really, parents have to be very vigilant about keeping an eye on their kids because we still want them to play with the rattle. We still want them to bomb. We still want them to do these things. We just have to be very careful about the site. Again, pain meds if they need it to keep comfortable, and elbow restraints if they're not being supervised. We don't recommend any kind of restraints normally, right? We want to use things like distraction, bonding, those type of things. But if we need them for a short period of time to let that area heal, we will use them.
Do they sleep in them?
Yeah, they often sleep in them. And because think about it, what if your kid's a thumb sucker? And just by chance in the middle of the night, they stick that thumb in there and they pop it open. And now they're bleeding and you don't know because they're sleeping. Exactly. They're going to choke on their own blood. So that could be super scary. So they often sleep in their restraints just so that they don't, because it's most of the time when sutures pop open, it's nothing malicious. It's just an accident. Things that we take for granted we're not even realizing we're doing.
So what we do to feed them?
They use a special nipple. We don't want them to suck really hard because, again, that's why they have that enlarged hole because we don't want them to work too hard and they can't really, you want the formula to basically fall in their mouth. They can do a little bit of a suck, but basically it's going to fall into their mouth. That's why we want to position them. Feeding becomes a whole chore. It's not just stick it in and go. We have to make sure that the parents understand to look for the signs that the child needs to rest, look and make sure they're swallowing, that they're not having to work too hard to get the formula. And there's different size nipples. They have different size holes for the kids. They look different based on what the kid has, what defect they have. So
Are they using this when we have a surgery?
yeah, for initially after surgery until it's healed. Mm-hmm. Yeah, because you have to be very careful. And we talked about this a lot of family support. Making sure, do they understand that they have to go see all these people? Do they have the numbers to all these people? Do they feel comfortable feeding the baby? I'm sorry, I'm going back. It just says feelings, bonding, fears. I mean, we make assumptions sometimes. Like, the parent may be stressed out because something silly. Like, so we don't ever want to just assume we know why they're stressed or why they're upset. We might say, oh, they're just upset because their baby looks different. They could be like, oh, I don't care what my baby looks like. I'm stressed because I can't get to the clinic on Tuesdays, and that's the only day my doctor has an appointment. So we have to talk with them and really get an understanding of what issues do you have with taking care of this baby, and how can we help you overcome those issues so the baby gets the best care possible. All right. Why don't we take a break real quick? Everybody good with this? Okay. Why don't we take a break and then